Bismillahirrahmanirrahim. My name is Dr. Hind Sharafuddin. I'm going to discuss with you in this presentation different forms of cell injury. But before we start, I'd like to give you a brief introduction on how we describe lesions in gross pathology by naked eye, there are different criteria that we should follow in our description. When we receive a specimen in our lab or when we describe a specimen in your museum, you should comment first on the organ. You should be able to identify the organ. Which organ are we talking about? Is it liver? Is it kidney? Is it heart? And I'm going to help you with this in each jar, how to identify each organ. Then we should comment on this organ. Its size, is it of normal size or enlarged or shrunken? We should also comment on the shape, the color of the organ, if there is a change in the color. If it's blackish, I'm thinking of gangrene. The consistency of the organ, is it firm, soft or hard in consistency? The external surface of the organ, does it have a smooth external surface or irregular external surface showing multiple masses on the external surface? And then the cut section. And by cut section we mean when we cut the organ in two halves, like we opening a book. Okay, then we should comment on the masses or the lesions we see within the organ. If I see within the organ a definitive mass or a definitive nodule which is not normally seen in this organ, I should comment on these masses. If it's single mass or multiple masses, it's important to comment on the number because there is interpretation of each criteria. And then I should comment on the site of the mass where it's located within the organ. I should also comment on the size of the lesion, the color, the shape, the consistency. Is it firm? Is it soft? Is it hard in consistency? And the outline, does it have a smooth outline or irregular outline? And the cut section of the mass. By cut section we mean when it's cut into half, what is the shape, the color of the mass? Does it have necrosis? Does it have characteristic features? What is the shape of the mass on the cut section? يبقى يا دكاترة احنا المفروض عندنا في الباثولوجي بنكومنت على العينات جروسلي بشكل معين. جروسلي يعني ايه؟ يعني قصدنا بالنيكد اي، يعني لما شفتها لما جات لي المعمل، او بالنسبة لكم انتوا لما بتشوفوا العينة في الجار المفروض تكومنت على ايه؟ اول حاجة انا لازم اعرف ايه الاورجن اللي انا بتكلم عليه. وفي اورجنز هتبقى فاميليار بالنسبة لكم، يعني سهل ان انتوا تعرفوا ان ده هارت. في اورجنز تانية ممكن يبقى صعب ان احنا نعرفها، فدي هقول لكم نعرفها ازاي جروسلي. ده مثلا ليفر، ده كدني. حتى بيبقى مطلوب منكم في الامتحان ان انتوا تقولوا الاورجن والdiagnosis و 2 diagnostic features. اسئلتكم بتبقى كده mention the organ, the diagnosis and 2 diagnostic features. فاول كلو ان انا اعرف الاورجن، لان ده برضه هيخليني دايركتد ناحية ليجنز معينة. تاني حاجة الاورجن ده بكومنت عليه ازاي؟ لازم اكومنت اول حاجة على السايز بتاع الاورجن، هل هو حجمه طبيعي ولا مثلا enlarged ولا shrunken، بالذات لو السايز ده ليه significance. يعني معظم الاورجنز بنقول slightly enlarged، ده ملوش significance اوي، لكن في اورجنز بيبقى من الليجن ان انا اكومنت على السايز بتاعها لانها بتبقى hugely enlarged. فده زي مثلا حاجة اسمها الماسيف سبلينوميجالي، فدي يعني it's part of the lesion. تاني حاجة بكومنت على الشيب بتاع الاورجن، الاكسترنال سيرفيس بتاعه، هل هو ليه سموث اكسترنال سيرفيس ولا ليه irregular external surface؟ الكبسول بتاعته بقت interrupted بليجن، في multiple nodules مثلا على الاكسترنال سيرفيس. بكومنت على الكولر، هل في change في الكولر بقى مثلا يلوش، فبفكر في حاجة زي fatty change. بقى في discoloration لونه مثلا بلاك، بفكر في جانجرين. الكونسيستنسي، هل هو soft ولا firm ولا hard in consistency. والcut section، الcut section قصدنا بيه ايه عشان دي هتتكرر معانا كتير؟ الcut section معناها لما فتحت الاورجن او لما فتحت الليجن قسمتها كده نصين وببص عليها بقى من جوه شكلها عامل ازاي. طيب لو انا لقيت within الاورجن definitive mass او definitive lesion نوديول كده جوه الاورجن، حاجه مش طبيعي ان انا الاقيها within الاورجن ده، المفروض اكومنت عليها ازاي؟ اول حاجه لازم اكومنت على النمبر. هل انا عندي single mass within مثلا الكدني اللي عندي، ولا عندي multiple masses؟ وده مهم لان المالتيبل ليجنز بتبقى لها ديفرنشال معين، بيبقى بفكر في حاجات معينه، والسنجل بفكر في حاجات تانية. وهتشوفوا حتى في سيكشن النيوبليزيا ان مثلا لما بشوف مالتيبل نوديولز في الليفر انا بفكر اكتر في ان دي ميتاستاسيز عن انها دي برايمري تيومر وذين الليفر. يبقى اول حاجه لازم اكومنت على النمبر. تاني حاجه السايت، هي لوكيتد فين وذين الاورجن نفسه. تالت حاجه بكومنت على السايز بتاعها، حجمها عامل ازاي، وبكومنت على شكلها الشيب، وبكومنت على الكونسيستنسي، هي فيرم ولا سوفت ولا هارد، لان ده برضو بيديني كلو. يعني الحاجات الهارد بنفكر اكتر في مثلا في ان انا بتكلم في مالجنانت تيومر، ولونها شكلها والكالر والاوتلاين، هل لها سموث اوتلاين، ده بيخليني افكر اكتر في حاجات بناين، ولا لها ريجولار وانفلتريتيف اوتلاين، فده بيخليني افكر اكتر مثلا في مالجنانت ليجنز. والكاب سيكشن بتاع الماس دي برضو لما قسمت الماس دي او فتحتها شفت شكلها عامل ازاي، لونها عامل ازاي، هل فيها نيكروزز، هل فيها حاجه كاركترستيك. يبقى ده كده الجنرال ايديا بتاعت الجراس باثولوجي، how to describe an organ in gross pathology. And you know, and by histopathology we mean the lesions, how we see the lesions and the organ under the microscope. These are your ILOs. At the end of this section you should be able to describe the gross pathology of reversible cell injury, which is fatty change in different organs. You should be able to describe the gross pathology of irreversible cell injury, different forms of necrosis in different organs. You should be able to differentiate between stromal fatty infiltration and fatty change, and also to differentiate between dry and wet gangrene, and describe the gross pathology of dystrophic calcification, and describe the gross and the histopathology of amyloidosis in different organs. These are the jars for today. We are going to go through each jar of them and describe, identify the organ, the diagnosis, and the features. These are, we have only one slide for today, which is amyloidosis in the. First, what do we mean by cell injury? As we know, cell injury is the effect of a variety of stresses. If these stresses are mild and moderate, so we are going to have a reversible form of cell injury in which recovery occurs if the stress or the inciting agent is removed. We have examples of reversible cell injury which are cloudy swelling and fatty change. In the irreversible form of cell injury, the form of stress is so severe and persistent that there is a cell death has occurred. Cell death can be in the form of necrosis or apoptosis. First, we are going to start with forms of reversible cell injury, and as we know, reversible cell injury could be in the form of cloudy swelling, which is also called hydropic change, and it means accumulation of water within the cytoplasm of the cell. And then we have fatty change, which is also called steatosis, and it means intracellular accumulation of neutral fat, and it's commonly seen within the liver. We commonly hear the word of fatty liver. دايما بنسمع الكلمة بتاعت ان البيشنت ده عنده دهون على الكبد. دهون على الكبد معناها انه عنده fatty change within the liver. It also can occur in non-fatty organs like the heart, as we are going to see in our example today. In our presentation, you are going to find in each jar first a picture of the jar in your atlas, and then a picture of the actual jar in the museum. This is the picture in your atlas showing a heart. The heart has it's opened longitudinally, so we can have a look inside the heart. As you know, the heart has an atrium and a ventricle. The atrium is referred to by a red arrow, and the ventricle is referred to by a green arrow. The heart here is slightly enlarged, and the myocardium, which is the muscle of the heart, and is referred to by a purple arrow, is diffusely pale yellowish in color, and it's soft in consistency. Normally, the myocardium of the heart is leafy red in color. Here, it's pale yellowish in color and diffusely pale yellowish in color due to the fatty infiltration within the fat accumulation within the cells, and it's soft in consistency. This is a photo of your actual jar in the museum. Also, it's the same jar, fat exchange of the heart, with the same description. It's slightly enlarged. The myocardium is diffusely pale yellowish in color, and it's soft in consistency. This is a back view of the same jar. Then we are going to proceed to the other forms of cell injury, which is the irreversible cell injury in the form of necrosis and apoptosis. Necrosis, as we know, is a localized area of death of tissue which later on undergoes degradation by hydrolytic enzymes liberated from dead cells, and it's associated with inflammatory reaction. We have 5 forms of necrosis: coagulative necrosis, liquefactive, caseous, fat necrosis, and fibrinoid necrosis. And as we know, apoptosis is a form of programmed or defined as programmed cell death, and it's in the form of cell suicide. When the cell is not needed, it undergoes programmed cell death, or what we call cell suicide. الخلية بتقتل نفسها بشكل منظم, programmed cell death, and it's not accompanied by inflammation. It may be a physiologic form of apoptosis, as what occurs in embryo. During the development of embryo, there are different structures that are necessary for the embryo but will not sustain within the fetal, within the after labor, so they undergo apoptosis. And we have pathologic form of apoptosis, like a tumor undergoes apoptosis under the effect of chemotherapeutic agent. Okay, in our presentation we are going to have different forms of necrosis. First, examples of coagulative necrosis, and as we know, coagulative necrosis occurs in solid organs. First, we have coagulative necrosis in spleen. The diagnosis of the jar here is splenic infarct, and as you see, it's referred to by this black arrow that we have different multiple lesions within the spleen. Okay, how we describe these multiple lesions? Considering the location, they are peripheral on location or subcapsular, which means they are located under the capsule of the spleen. They are wedge shaped or triangular in shape. The base is directed towards the capsule and the apex is directed towards the hilum. They are pale in color and they are multiple. The overlying capsule is fibrotic. يبقى دكاترة زي ما احنا شايفين هنا عندنا ده سبلين، وانا هقول لكم في السلايد اللي بعديها ازاي اعرف السبلين. ده الكات سيكشن. كات سيكشن معناه ان السبلين مفتوح قسمينه نصين، وشايفين احنا في الكات سيكشن مالتيبل ليجنز، حتى متشاور على واحده فيهم بالبلاك ارو. والمالتيبل ليجنز دول شكلهم ويدج شيب، شبه الويدج كده او شبه التراينجل. ده وصف الانفاركت، ان هي بتبقى دايما ويدج شيبد او بتبقى تراينجلر ان شيب، ودايما البيز بتاعها بتبقى دايركتد towards الكبسول، يعني towards البريفري، والايبكس بتاع التراينجل او بتاع الويدج ده بيبقى دايما دايركتد towards الهايلم. الهايلم اللي هو السنتر بتاع الاورجن اللي بيدخل منه البلاد فيسلز. ودايما الانفاركت بتاخد الشكل ده لان هي بتبقى following البلاد سبلاي والتريبيوتريز بتاعه البلاد فيسلز اللي هي حصل لها اوكلوجن، فدايما بتاخد الشكل ده لانها following البلاد سبلاي، وبيبقى لونها بيلر نتيجه ان هي حصل لها healing by fibrosis. It's the same jar with the same description. This is a frontal view, and this is a posterior view. We identify the spleen as organ by something called notch on the external surface. It's located on the anterior border of the spleen. This is the notch. This is how we identify the spleen as organ by the splenic notch. يبقى دكاترة احنا بنعرف السبلين بان على الانتيريور بوردر بتاع السبلين بيبقى في حاجة اسمها نوتش. النوتش دي يعني زي داخلة كده في السيرفس بتاع السبلين، دي اللي بتخليني اعرف ان انا في الاورجن بتاع السبلين. Okay, we have here another form of coagulative necrosis in the kidney, which is the renal infarct. This is the jar of the renal infarct. How to identify the organ as kidney? The kidney is bean shaped and it has indentation towards the hilum. It's referred to by this red arrow. The cut section of the kidney showing multiple lesions, referred to by this black arrow. They are pale in color, wedge shaped or triangular in shape. The base is directed towards the capsule and the apex is directed towards the hilum. يبقى دكاترة هنا عندنا ده برضو infarction بس في organ تاني اللي هو الكدني. انا بعرف ان هي كدني ازاي؟ بان هي bean shaped يعني شبه حبة الفاصوليا، وزي حبة الفاصوليا بيبقى لها زي indentation كده عن في النص، ده اللي هو بيبقى عند الهايلم بتاع الكدني. الهايلم هو المكان اللي بيدخل منه البلاد فيسلز عشان تسبلاي اي اورجن. الكات سكشن بتاع الكدني باين فيه multiple lesions كلها موجودة على البريفري ومتشاور لها بالبلاك ارو دي، والليجنز دي لونها pale in color، شكلها paler عن surrounding renal tissue، وبيبقى برضو لها نفس الشكل ان هي بتبقى wedge shaped او triangular in shape، والبيز بيبقى directed towards الكبسول والapex is directed towards. This is the actual jar showing renal infarct. Just for your knowledge, whenever we describe an infarct in the coagulative necrosis forming infarct, it always has the same description. It's triangular in shape or wedge shape. The capsule is directed towards the base is directed towards the capsule and the apex is directed towards the hilum, and there are multiple lesions. Then we proceed to another form of necrosis, which is liquefactive necrosis. This is an example of liquefactive necrosis. Here the brain infarct. We know that liquefactive necrosis occurs in the brain. We know that we are in a brain. This is just one hemisphere of the brain or a slice of the brain. When we look at the external surface, we can see the sulci and the gyri. You know, the gyri are the elevations of the brain, and the sulci are the depressions between these elevations. Okay, so this how we identify that we are in a brain. We have gyri and sulci on the external surface of the brain. Okay, how we describe healed brain infarct: cut section of a cerebral hemisphere showing multiple cystic areas surrounded and traversed by glial tissue, giving what we call honeycomb appearance. ايه الهونيكومب appearance ده؟ اللي هو زي خلية النحل. So we have again multiple cystic spaces surrounded and traversed by glial tissue. What is glial tissue? This is a special form of fibrosis that occurs in the brain. This is a footage of your actual jar showing multiple cystic spaces surrounded and traversed by glial tissue, giving a honeycomb appearance. Then we have another form of necrosis, which is caseous necrosis, and as we know, this special form of necrosis occurs with tuberculous infection. Here we have an example of caseous necrosis occurring in the lymph nodes. As we know, caseous necrosis is a form of necrosis that occurs in the tuberculosis. So the diagnosis here is tuberculous lymphadenitis. how we describe this lesion? We have multiple lymph nodes enlarged and matted together. What do we mean by matted together? We mean they are adherent to each other. The cut section of these lymph nodes shows this yellowish material, which is caseous material. How we describe the caseous material? We say it's yellowish in color and cheesy-like. It's very characteristic to mention the cheesy-like in the description of caseous necrosis. So we have yellowish, cheesy-like necrotic material. This is the description, the actual description of caseous necrosis. يبقى يا دكاترة احنا هنا عندنا ده فورم اوف كيزيوس نيكروزس بيحصل يعني احنا عارفين كيزيوس نيكروزس بيحصل في التي بي. فالدايجنوزس بتاعنا تيوبركلوس ليمفادينايتس. ازاي بنوصف التيوبركلوس ليمفادينايتس؟ احنا عندنا ده جروب اوف ليمف نودز، والليمف نودز دي اكبر من حجمها الطبيعي. المفروض حجم الليمف نودز ما يبقاش اكتر من 1 سنتيمتر. فدلوقتي انا اول حاجه بالنسبه للسايز ان انا عندي جروب اوف ليمف نودز انلارجد. كمان في حاجه تانية مش طبيعيه ان هما ماتت توجذر. يعني ايه كلمه ماتت توجذر؟ يعني لازقين في بعض. المفروض نورمالي الليمف نودز بتبقى مفصوله عن بعضها، حتى لو انلارجد وفيهم ليجن بلاقيهم مفصولين عن بعضهم، مش لازقين في بعض وسايحين على بعض بالشكل ده. فهم ماتت توجذر. within الليمف نودز دي الكات سكشن بتاعها مبين ماتيريال شكلها غريب شويه، تشيزي لايك بنقول عليها شبه الجبنه، ويلوش ان كولر. ده الديسكريبشن بتاع الكيزيس ماتيريال، وده كاركترستيك. يعني لما اجي اوصف اي كيزيس نيكروزس لازم اقول الكلام ده، لازم اقول ان هي يلوش ان كولر وتشيزي لايك نيكروتيك ماتيريال. Again, the same description. We have multiple lymph nodes enlarged, matted together. Cut section shows multiple foci of yellowish, cheesy-like necrotic material equals caseous necrosis. Then we are going to proceed to intra and extracellular accumulations, different forms of intra and extracellular accumulations. First, fat accumulation. If fat accumulation is intracellular, this is called fatty change, and we actually described the jar of fatty change. Fat accumulation extracellular is called stromal fatty infiltration, and we have an example of stromal fatty infiltration occurring in the heart. Stromal fatty infiltration is the deposition of mature fat in the stroma, which is the connective tissue in between the cells, which means the fat is accumulated extracellularly, and it occurs in obesity. في الناس الأوبيز بنشوف فيهم موضوع السترومال fatty infiltration ده. usually بنشوفه في الهارت، ممكن نشوفه كمان في البنكرياس أو في other different organs. This is an example of stromal fatty infiltration in the heart. The heart here is opened at the level of the ventricle and showing part of the aorta with the aortic valves in between the aorta and the ventricle. This is the ventricle referred to by a red arrow, and this is and above it is the part of the aorta. Okay, what we see here in the stromal fatty infiltration, that the pericardial fat is increased. What is the pericardial fat? Is the fat surrounding the heart. Peri, which means around, cardium, which means the heart. So normally there is a pericardial fat, but it's here increased due to the stromal fatty infiltration. It's referred to by green arrow. We also have yellowish streaks in between the myocardial fibers. So we have increased the pericardial fat, and the second description is that we have fatty streaks extending between the myocardial fibers. يبقى دكاترة ده الجار بتاع السترومال فاتي انفلتريشن برضو في الهارت. الهارت هنا مفتوح longitudinally at الليفل اللي هو ما بين الفنتريكل والاورتا. يعني شايفين الفنتريكل وهو فاتح على الاورتا، وان بتوين الاورتيك فالف اللي هو بيبقى عبارة عن 3 فالفز وشكلهم زي الكاب شيب دي كده او زي الجيوب. تمام. ايه بقى اللي احنا شايفينه؟ الهارت نفسه ما فيهوش المصل، السيلز بتاعت الهارت نفسها ما فيهاش مشكله. المشكله ان في فات accumulating في الاستروما، سواء حوالين الهارت او within الهارت. حوالين الهارت اللي هو بنسميه البيريكارديال فات. كلمه بيري يعني around، يبقى البيريكارديال فات increased عن الطبيعي. يبقى دي اول نقطه عندي، بقول ان البيريكارديال فات is increased. تاني حاجة زي ما انتم شايفين في نقط لونها يلوش كده او مبيضة شوية in between موجودة منتشرة within المايوكارديال fibers، فدي برضو نتيجة السترومال fatty infiltration. This also a picture of our jar showing the same description front view, and this is a back. Then we have another example of a stromal fatty infiltration occurring in the kidney. The kidney is normal in size, and as you see here the kidney is bean shaped as we said. The kidney is surrounded by excessive amount of perinephric fat. Peri means around, nephric the kidney. Nephric refers to nephric tissue which is the kidney, and there is increased fat in the renal pelvis which is referred to here by a green arrow. Okay, so the fat is also increased in the renal pelvis. ده دكاترة الجار بتاع السترومال فاتي انفلتريشن في الكدني. الكدني زي ما قلنا هي بتبقى شبه حبة الفاصوليا، واللي بيبقى عند اللي هو الحتة اللي في النص اللي داخلة دي اللي هو بنقول عليه الهايلم او الرينال، اللي بيبقى برضو رينال بلفس اللي هو طالع منه هيعمل بعد كده اليوريتر. فكمية الفات الكدني نفسها مفيهاش مشكلة، بس كمية الفات الكتيرة اللي سواء حوالين الكدني او جوه رينال بلفس اللي هي متشاور عليها بالجرين ارو ده كله نتيجة الاسترومال فاتي انفلتريشن. فبنقول في الديسكريبشن ان في excessive amount of perinephric fat، وان برضو في عندنا increase في الفات around renal pelvis اللي هو بنقوله البري pelvic fat. This is an actual photo of our jar in the museum showing stromal fatty infiltration in the kidney. This is a front view. Then we are going to proceed to another topic, which is gangrene. What do we mean by gangrene? Gangrene is necrosis of the tissue with superadded putrefaction, and as we know we have two forms of gangrene or three forms of gangrene, but we are going to have example of just two of them: dry gangrene and moist gangrene. We have an example of dry gangrene in the hand. The organ here is hand. Okay, we have first loss of medial 3 fingers of the hand and the distal part of the index finger. They are totally lost due to the gangrene. The distal part of the hand is dry black in color. Okay, and it's shrunken or what we call mummified due to the dryness. And then here we can see that the line of demarcation between the gangrenous part and the viable tissue is well defined. This is very characteristic in the description of the dry gangrene anywhere. So again we have dry gangrene in the hand showing loss of the medial 3 fingers and the distal part of the index finger. The distal part of the hand, distal part means the most distant part of the organ. The distal part of the hand is dry black in color and shrunken or mummified. The line of demarcation between the gangrenous part and the viable tissue is well defined. يبقى دكاترة دي عندنا يعني example of dry gangrene in the hand. يبقى الأورجن عندي هنا الهاند، اللي باين عندنا ان انا في عندي الثلاث صوابع يعني lost totally نتيجة الجانجرين، وفاضل الاندكس فينجر والثumb، والاندكس حتى مش كله موجود، ده جاست موجود الجزء اللي هو البروكسيمال، والجزء الديستال is totally lost. خلاص. تاني حاجة الديستال بارت بتاع الهاند باين ان هو لونه dark blackish in color، وان هو ماميفايد معرض كده والشرانكن نتيجة الدراينس، واحنا قلنا ان كلمة ماميفيكيشن دي دايما بتحصل من دراي جانجرين وكاركترستيك في الديسكريبشن اوف ذا دراي جانجرين. تاني حاجة برضه كاركترستيك في الديسكريبشن اوف دراي جانجرين عشان افرقها من الويت جانجرين هو اللاين اوف ديماركيشن. هنا انا في الدراي جانجرين اقدر اقول بالظبط فين التيشو ابتدى وفين الجانجرينس تيشو انتهى، فاللي متشاور عليه بالجرين ارو ده هو اللاين اوف ديماركيشن ما بين الفايبل تيشو اللي هو موجود بروكسيمالي والجانجرينس تيشو اللي هو موجود distally. Then we are going to have examples of wet gangrene, one in the foot and the other in the intestine. This is moist gangrene in the foot, as we find it in diabetes. We call it diabetic foot. Here we can see that the little toe is dark blackish in color. Okay, the skin of the foot, as you see, is swollen and macerated, and the line of demarcation is ill-defined. Okay, again we have here a foot showing with gangrene. The little toe is black in color and mummified, and the skin of the foot is swollen and macerated. The line of demarcation is ill-defined. This is a back view of the same joint, but the lesion is not apparent in the. Then we have the moist gangrene in the intestine. How we identify the organ as intestine? The intestine appears as a tubular structure with a smooth external surface. This is part of the small intestine, and it's attached by it shows a mesentery attached to its one of its border. Okay, and here we can see part of the small intestine showing a poorly defined dark brownish gangrenous area, and the peritoneal surface is dull, opaque, and lustreless. What is the peritoneal surface? Is the external surface of the small intestine is covered by something called the peritoneum. Okay, what is peritoneum? It's covering of the small intestine that is usually translucent and shiny. When we have something wrong within the intestine, it usually it's usually reflected on the peritoneal surface, and it comes dull and lustreless, which means there is no shine in it due to the underlying lesion. يبقى ده كده احنا عندنا دجار moist gangrene of the small intestine. انا بعرف منين انها small intestine؟ ان هي حاجة شبه التيوب كده، وبيبقى لها smooth surface، وبيبقى فيه mesentery، حاجة زي الستارة كده attached ل one of its borders. باين في الوول بتاع السمول intestine ان انا في عندي lesion لونها براونش كده in color و ill defined، مش قادر احدد المعالم بتاعتها كويس، وده طبعا going مع ان هي moist gangrene. والperitoneal surface ده بيبقى covering normal بتاع السمول intestine، حاجة اسمها البريتونيوم. المفروض ان هو بيبقى فيه لمعة كده، وانه بيبقى transparent، يعني اقدر اشوف through it ال underlying structure. فلما بيبقى فيه في الانتستين مثلا inflammation او اي region في الانتستين كتير بتبقى reflected كمان على البريتونيوم، فهنا البريتونيوم ما بقاش فيه نفس اللمعة، فبقى lusterless وdull. ده نفس الجار اهي الليجن عندنا is encircled by a green circle. Then we are going to proceed to the pathological classification. We have two forms of pathological classification: metastatic pathological classification and dystrophic. The example that we are going to have is an example of dystrophic calcification. Here we have a leiomyoma, and we have dystrophic calcification in leiomyoma. Leiomyoma is a common tumor that occurs in the uterus. Here we have a uterus that is enlarged in size and distorted in shape. This is not it has a nodular external surface, as we see here, so it's enlarged in size and distorted in shape. This is the uterus. Cut section shows multiple well-defined masses, as we see here, and these masses has a whitish whirly cut section. One of the masses show focal areas of a chalky white calcification. Whenever we describe calcification, we describe it as a chalky white areas. يبقى هنا ده الجار of dystrophic calcification in leiomyoma. leiomyoma ده اللي هو الورم الكومن اللي كلنا عارفين، اللي هو اسمه الورم الليفي اللي بيحصل في اليوترس. اليوترس بيخلي اليوترس enlarged، فده مش النورمال سايز بتاع اليوترس. اليوترس is enlarged و distorted، يعني مش الشكل الطبيعي بتاعه. يعني ده المفروض الكافيتي بتاع اليوترس، والفندس المفروض يبقى هنا. الفندس مكانه is translocated نتيجة ان هي ال different masses دي عاملة لخبطة شكل اليوترس، واللي احنا شايفينه طالع منه من الجنبين ده اللي هو الفالوبيان تيوب، واللي بتبقى attached للأوفري. المهم عندنا ان اليوترس is enlarged and distorted، ولما فتحناه زي ما احنا شايفين باين فيه multiple masses. احنا قلنا لما يبقى عندنا masses لازم اقول هما single ولا multiple، يبقى انا في عندي multiple masses دي كلها multiple ليوميوماتا في اليوترس، ولونهم وايتش او تان كولرد، وليهم وورلي كات سكشن. وورلي زي الدوامه كده، ده وصف الليوميوما. وواحده منهم فيهم ارياز لا شكلها وايتش ان كولر، شبه لون الطباشير بالظبط، فبنقول عليها تشوكي وايت ان كولر، وده وصف الكالسيفيكيشن تشوكي وايت ارياز. ده نفس الجار showing dystrophic calcification in leiomyoma of the uterus. Then we are going to proceed to our last topic, which is amyloidosis. We have first an example of amyloidosis in the liver. How we identify this organ as liver? The liver is identified by the portal tracts, that is referred to by these green arrows. Portal tracts are pipe-like structures seen within the liver. Okay, so this is how I identify this organ as liver. Okay, considering the size of the organ, the liver is enlarged. It has a smooth external surface and a sharp border. Normally, the borders of the liver are rounded, but here due to the deposition of the amyloid material and enlargement of the liver, the liver has sharp border. It's firm in consistency. Cut section of the liver is dark brownish in color. It's mottled and showing these brownish foci that are semi-translucent and waxy in appearance. It's very characteristic in the description of amyloidosis to say that the material is waxy in appearance. يبقى احنا هنا عندنا الجار بتاع الاميلويدوزس. انا بعرف منين الاول ان ده ليفر؟ بعرفه من حاجه اسمها بورتال تراكس. البورتال تراكس دي بتبان لي بالجروس مايكروسكوبي انها الفتحات اللي انتوا شايفينها اللي شبه البايبز كده، كانها بايب لايك ستراكشرز، كانها خراطيم كده مثلا، فتحات كبيره وصغيره within الليفر. يبقى ده اللي عرفني ان انا في الليفر، البورتال تراكس. اوكي، طيب شكل الليفر عامل ازاي؟ الليفر انلارج، ده مش النورمال سايز بتاع الليفر. الاكسترنال سيرفيس لو شفناه على طرف الجار كده شكله سموث اكسترنال سيرفيس. البوردر بتاع الليفر شارب يعني، وده يعني ما بقاش راوندد. هو النورمال البوردر بتاع الليفر بيبقى راوندد، هنا نتيجه الديبوزيشن اوف ذيس ماتيريال والانلارجمنت اوف ذا ليفر بقى شارب بوردر. اوكي، الكات سكشن بيبقى showing ايه؟ الكات سكشن اوف ذا ليفر دارك براونش ان كلر وموتلد يعني منقط، مبين النقط الكتير اللي لونها براونش ان كلر، وسيمي ترانسلوسنت يعني كانها شفافه شويه، وواكسي ان ابييرنس يعني شبه الشمع. وده كاركترستيك في وصف الاميلويدوزز ان انا اقول ان الماتيريال از واكسي. Again, this is our jar amyloidosis in liver. This is the back view of the also amyloidosis in the liver, and as we see here in the liver amyloidosis, we have only a slice of the liver, not also amyloidosis. The same jar, same description, amyloidosis in the liver. Then we have amyloidosis in the spleen. This is also a part of the spleen, not the whole spleen, showing that the spleen is firm in consistency or rubbery in consistency. It has a smooth external surface. It has a mottled section showing these multiple spots that are semi-translucent and waxy in appearance. Here we can see the notch of the spleen to identify that this is a spleen. This is part of enlarged spleen, firm or rubbery in consistency. Cut section is mottled, showing multiple brownish areas, semi-translucent, waxy in appearance. This is the description of the amyloid material. Brownish, translucent, waxy in appearance. This is also an example of amyloid. Considering the slides for today, we have amyloidosis in the... As we know, amyloidosis is seen as an extracellular material. It's a proteinaceous material seen extracellularly. By H&E, it appears as homogeneous, eosinophilic, structureless material. It's like you have colored these areas by pink color. Structureless means that there are no cells within this material or no cellular debris. There is a special stain to identify amyloidosis called Congo red. It appears by this special stain as orange color, and it should be confirmed by a special light called the polarized light. It appears by this special light as green birefringence. We have also another special stain called the methyl violet. It's stained pink by this methyl violet, and it also can be identified by immunohistochemistry, which are antibodies that are directed against certain proteins within the amyloid material to identify the amyloidosis. يبقى دكاترة أنا الاميلويدوزز بشوفه تحت الميكروسكوب كاكسترا سيلولار ماتيريال. احنا عارفين هو اكسترا سيلولار مش within the cells، وبيبقى لونه بينك، ايزينوفيليك يعني لونه بينك، وبيبقى هوموجينس يعني وستراكشرلس، كأني بالظبط مسكت قلم بينك ولونت بيه السلايد، وما فيهوش اي سيلز within this material. السيلز موجودة حوالين الماتيريال. ممكن اشوفها كمان بسبيشال ستين، حاجه اسمها الكونجو ريد، بيبقى لونها بالسبيشال ستين اللي هي الاميلويد ماتيريال دي اورنج، بس لازم اعمل لها كونفيرم. يعني لما اعمل ستين بالسبيشال ستين لازم اشوفها بلايت معين اسمه البولارايزد لايت. بتبان في البولارايزد لايت ده حاجه لونها جرين ومشعه كده، تمام. وفي اذر برضه سبيشال ستين اسمه الميثايل فايلوت، بيبقى لونها بينك. او ممكن ايدنتيفاي بحاجه اسمها الاميونوهيستوكيمستري، ده تكنيك بيتعمل، بيبقى انتي بوديز معينه دايركتد اجينست بروتين معين within الماتيريال سبيسيفيك للماتيريال دي. اوكي. This is your slide amyloidosis within the liver by H&E. This is the usual stain, which is hematoxylin and eosine. As we see here, I'm going to point to the liver cells by a green arrow. The liver cells are normal. There is no pathology within the liver cells. They usually appear as these structures. They are cuboidal in shape with ample eosinophilic cytoplasm. But what is abnormal here, that we have eosinophilic material, extracellular, pink in color, homogeneous and structureless, and this material is compressing the hepatocytes causing their atrophy by pressure atrophy. يبقى زي ما احنا شايفين في السلايد هنا ده amyloidosis within the liver. لو بصينا على السيلز بتاعه الليفر نفسها اللي هي الهيباتوسايتس هنلاقيها شكلها طبيعي جدا، مفيهاش اي مشكله. هو ده الشكل الطبيعي بتاع الهيباتوسايتس، بيبقى شكلهم كيوبويدال ان شيب زي مكعبات كده، وبيبقى ليهم سيتوبلازم كتير ولونه بينك، فهم نفسهم ما فيهمش مشكله. بس لو بصينا حواليهم وان بتوين السيلز دي هنلاقي الماتيريال اللي لونها بينك، اللي هي بالظبط كاننا مسكنا قلم لونه بينك ولونا ما بين السيلز دي. وطبعا السيلز ابتدت تفرق وتبعد عن بعضها وحجمها يصغر نتيجه ان الماتيريال دي ضاغطه على السيلز فعملت فيها اتروفي. دي برضو this is your slide، يعني باين فيها نفس الكلام، اللي هي الاميلويد ماتيريال اللي هي pink extracellular material. وشايفين في النص في اللي هو البورتال تراكت. ده النورمال اركيتكتشر بتاع الليفر، ده اللي نقصده بان النورمال اركيتكتشر اوف ذا ليفر از بريزيرفد، ما فيهوش هو نفسه ك architecture is not distorted. Okay. يبقى this is your slide amyloidosis in the liver. We have this pink extracellular material referred to by these red arrows, and the green arrow shows the portal tract, which is normally seen within the liver, meaning that we have a normal architecture of the liver preserved with normal with lesions seen extracellularly, which is the amyloid material causing pressure atrophy of the hepatocyte. Again, your slide showing extracellular homogeneous pink material. Again, extracellular homogeneous structureless eosinophilic or pink material, which is the amyloid material. It's seen extracellular in between the hepatocytes. As we said, we could see this. We could identify this material by special stain called the Congo red. They appear orange in color, as we see here, And if we look at this material by special light called the polarized light, they will appear as green birefringence as we see here. Okay, this is the end of our presentation. I'm going to proceed now to the questions. I hope you could be able now to answer these questions. What is the name of this appearance? What do we have here? Hypertrophy, fatty infiltration, brown atrophy, fatty change. We actually took this chart in our presentation. We have here fatty change. What other organs could show this change, fatty change? Liver, we said fatty liver. Name this process. Necrosis. Describe the area of the pointed structure. We have here multiple infarct within the spleen, splenic infarct. We describe infarct as multiple lesions, wedge-shaped or triangular in shape. The base is directed towards the capsule and the apex is directed towards the hilum, and they are pale in color. Name this process. Also necrosis. Describe the area of the pointed structure. We have multiple cystic spaces surrounded and traversed by glial tissue, giving what we call honeycomb appearance. This is a form of liquefacted necrosis occurring in the brain. Identify the lesion. Tuberculous lymphadenitis. Describe the lesion pointed by the arrow. We have cut section of the enlarged lymph nodes matted together. Cut section showing necrotic-like material, yellowish in color and cheesy-like. Define the lesion. What we have here, we have dry gangrene of the hand. Name the pointed area. We said this is the line of demarcation. Identify the lesion. This is wet gangrene of the small intestine. This condition is associated with what? Edema. Identify the lesion and the organ. This is an example of amyloidosis in the spleen. Describe the gross feature of the pointed areas. We said that the amyloid material looks grossly as what? Brownish, translucent, waxy in appearance. Identify the lesion. Amyloidosis in the liver. Mention the location. This material is located extracellular. Okay? Choreorexis means fragmentation of the nucleus. Which of the following is not a feature of moist gangrene? Mummification is evident. As we know, mummification is evident in the dry gangrene. A 40-year-old female patient has sudden onset of severe abdominal pain. She has laboratory findings that include increased serum levels of lipase and amylase. ده يفكرني بإيه؟ An abdominal CT scan reveals pancreatic lesion. So احنا بنفكر دلوقتي في ايه؟ في ان البيشنت عندها ايه؟ عندها acute pancreatitis وحصل release للانزيمز within the pancreas which are the lipase and the amylase. طب ده هيعمل ايه؟ Which of the following cellular changes is most likely to accompany these findings? Fat necrosis نتيجة the effect of these enzymes on the surrounding fat. Which of the following is not a site for dystrophic calcification? Dystrophic calcification اتفقنا انه بيحصل في ال tissue، بيحصل في الابنورمال tissue زي التيومرز. يبقى ممكن يحصل في الاثيروب، ممكن يحصل في dead parasite، ممكن يحصل في الفات necrosis، ممكن يحصل في degenerated tumors. لكن renal tubules ده normal structure، هيحصل في dystrophic calcification ليه؟ يبقى is not a site for dystrophic calcification. Thank you. Now we come to the end of our presentation. I hope that everything is clear by now. Good luck in your exams and stay safe.